All right, today we're putting on our detective hats. We're going to dive into a medical mystery that, honestly, affects millions of people. Hives.
I mean, you know the feeling, right? One minute your skin is totally fine. The next, bam! You've got these super itchy, raised welts that just seem to pop up out of nowhere. It's so frustrating, so confusing, but believe me, you are not alone in this.
Get this, about 20% of us will get hives at some point in our lives. That's 1 in every 5 people. It's a huge number, right? And that's exactly why we need to dig in and really understand what's going on with this condition.
Okay, so here's our game plan. We're going to cover what hives actually are, dig into the root causes, talk about how you get a diagnosis, check out the modern treatment playbook, and then we'll take a little peek into the future. All right, Section 1, let's start at square one. What are we really talking about when we say hives?
So, the fancy medical term is urticaria, and it's basically defined by those classic itchy welts. Doctors call them wheals. And sometimes you might also get this deeper swelling called angioedema along with it.
Okay, but here's where it gets interesting, and it's a really key difference. The hives themselves, those wheals, they're kind of fleeting. They pop up, drive you crazy, and then disappear in less than 24 hours, only to maybe show up somewhere else. But that deeper swelling, the angioedema, that can hang around for up to 3 days. And that difference in timing, it's a massive clue for doctors.
And this brings us to probably the single most important dividing line when it comes to hives, the 6-week mark. This is the big one. If your hives are gone in under 6 weeks, that's called acute. But if they're still showing up after 6 weeks, well, now you've entered the world of chronic urticaria. And that's where the mystery really deepens.
So if these things are sticking around for months, what is going on? A lot of people just assume, oh, it must be an allergy. But for these chronic cases, it's usually not that simple. The trigger is almost always coming from inside your own body.
So, researchers have figured out there are basically 2 main internal pathways, they call them endotypes, that cause your body to, well, attack itself and create hives. You can kind of think of it like 2 different ways your immune system can get its wires crossed.
So let's break down those 2 crossed wires. First up, you've got type 1, the autoallergic route. This is where your body makes allergy antibodies, called IgE, but they get confused and start targeting your own skin. This kind tends to respond really well to a class of drugs called biologics. Then you have type 2, 2b, the autoimmune path. This one's a bit different. It uses other antibodies, called IgG, to directly attack the very cells that release histamine. It's a more direct assault, and it often responds better to a different kind of drug called cyclosporine.
So with these complex causes, how on earth do doctors figure out which path you're on? Well, the good news is the whole diagnostic process has gotten a lot simpler and more focused.
You know, it all starts with a pretty straightforward clinical exam. After that, doctors usually only need a handful of basic lab tests, nothing too crazy. We're talking a CBC, that's a complete blood count, some markers for inflammation, and a TSH test to check your thyroid, because thyroid problems can sometimes be linked to hives. They'll also use questionnaires to help you track how bad your symptoms are. But the absolute most important thing, they have to make sure those welts are gone in 24 hours. That's how they rule out something more serious called vasculitis.
Now, things can get a little tricky. What if a patient has the swelling but no hives? Then doctors have to look for other culprits, like side effects from medication. And this is where a really crucial piece of data comes in. For a common type of blood pressure medicine, ACE inhibitors, the risk of causing this kind of swelling is 3 to 5 times higher in Black patients. That is a huge difference, and knowing this is absolutely vital for getting the diagnosis right and keeping patients safe.
All right, let's talk solutions. We're moving into the modern treatment playbook. And the best part is, there's now a really clear step-by-step approach to get this thing under control.
Okay, so this is pretty much the standard of care now. You start at step 1, second-generation antihistamines, the non-drowsy kind, and you can go up to 4 times the normal dose. If that doesn't cut it, you move to step 2, adding in a biologic, like amylizumab or one that's on its way called dupilumab. Still not working? For those really tough cases, there's step 3, where you might try cyclosporine or maybe tweak the biologic dose. And check out step 4. This is important. Steroids are only for short-term emergencies, for bad flares. They are not a long-term plan.
But, of course, treatment has to be tailored to the person. It's not one size fits all. So, for example, during pregnancy, some antihistamines are considered safer than others.
For kids 12 and over, we now have biologics as an option, which is great news. And for older folks, it's super important to stay away from those drowsy first-gen antihistamines and to double-check all their other meds for any bad interactions.
And all of this brings us to what I think is the most exciting part. What's next? We are seriously walking into a whole new era of personalized medicine for hives, and it's pretty amazing.
I mean, just take a look at what's in the pipeline. These aren't just pipe dreams. These are actual therapies in late-stage development. You've got rimibrutinib, which is showing fantastic results. Then there's barzolvolimab, which works in a completely different way and is giving people long-lasting relief. So this isn't just about having more pills to try, it's about having smarter options that go right after the specific root cause.
And this quote really says it all, doesn't it? The whole field is changing, and it's changing fast. We're moving towards treatments based on a person's specific endotype. We've got more biologics to choose from, and this pipeline is just full of promise. It's offering real, tangible hope, especially for people who've been struggling for years.
So as we wrap this up, I want to leave you with a final thought. We're shifting from just trying to quiet down the symptoms to actually targeting the precise thing that's causing the problem in the first place. And as the science gets more and more personal, you have to ask, right? Could a future without chronic hives actually be within reach?